talk about mental health, which is my area of expertise, and I've always counted it an honor. I've been given 40 minutes. You know, he said 30 to 40 minutes, so I will take 40. So, so I'm taking 40 minutes to discuss this. And the challenge is even a whole day won't be enough to compare notes when it comes to depression. But let's see how far we can go. Depression and anxiety, rather. Let's see how far we can go within the next 40 minutes. I've set my own timer. So we're looking at understanding depression and anxiety, early signs, treatment, and support strategies. I was discussing with Rita a while ago, and I told her because I'm using a phone to join in. I normally use my laptop, but I wouldn't know why I couldn't do that this evening. So I'm using a phone to join in. I can't share my screen, but I'll be very glad to share the slide deck for this interaction immediately after. So she's going to share it with all of us. I'm looking at depression, understanding depression, anxiety, early signs, treatment, and support strategies. So by way of introduction with regard to this stuff, depression and anxiety, just as Mr. Yomi has said, they've become two of the most prevalent mental health challenges worldwide, affecting people, individuals across age groups, occupations, cultural contexts. In fact, we call depression the common cold of mental illness. We describe it as a persistent disturbance in mood, cognition, and functioning. Persistent disturbance in mood, cognition, and of course, functioning, while anxiety refers to excessive fear, worry, or tension that interferes with daily life. So we are merging these two concepts together for the purpose of our discussion this evening. Recent global epidemiological data shows that depression now contributes significantly to disability adjusted life years. And then anxiety disorders, they are among the most common psychiatric conditions, both in clinical and community settings. I'm getting an interference. Are we able to just mute or yes? Thank you, everyone. So in academic and professional environments, rising psychosocial stressors, economic instability, social isolation, digital overload, they have contributed to an increased mood and anxiety symptoms. In our dear country, Nigeria, there are so many things that we look at that have contributed to the increase in depression and anxiety. Of course, limited mental health services, cultural barriers, they tend to delay help seeking, causing symptoms to worsen even before individuals receive treatment. So we'll be, like I said from the outset, we'll be exploring a comprehensive understanding of early signs, treatment options, evidence-based support strategies, and we'll be integrating local and global research and so forth in providing relevant insight. And I always say something whenever I have the opportunity to interact with people. I always say this, that we are not just here for ourselves. We are here for our loved ones, our friends, our well-wishers. There is something you would hear this evening that would help you guide a loved one appropriately towards receiving the appropriate assistance that they need. So I would request us to just keep an open mind while we have this particular interaction. Let's start by looking at depression in modern clinical psychology. It is more than sadness. It's a clinically significant condition that is characterized by low mood, persistent low mood, loss of interest, fatigue, cognitive impairment, disruption in sleep, and of course, appetite. The DSM, according to the DSM, the Diagnostic and Statistical Manual of Mental Disorders, which is a compendium of all of the mental disorders, according to the American Psychiatric Association in the world, according to them, So according to the DSM, depression impairs social, occupational, and emotional functioning. And I want you to note this particular thing I've said. That's what we call functional impact. It impairs social, occupational, and emotional functioning. Recall I mentioned something about persistent low mood. So if you have low mood, right, and it doesn't impair social, occupational, emotional functioning, then we cannot classify it as depression. Now, I'm going to get to this particular information I mentioned at some point, maybe as we begin to wrap up, when we, yes, I'll mention something about it and tie it together with something that we currently experience world over, especially amongst young people. So depression is associated with dysregulation in neural circuits that involve the prefrontal cortex in the brain, amygdala, and then the hippocampus. Now, and also people, researchers have said that serotonin is indicted in depression. Neurotransmitters like norepinephrine, serotonin, dopamine, they are all indicted in depression. Recent research highlights that depression develops from a complex interaction of genetic vulnerability. So the role of genetics is there, environmental stress, the role of stress is there, personality traits, and then chronic medical condition. In the Nigerian context, socioeconomic stress, unemployment, high level unemployment, as we know, and I'm trying as much as possible not to delve into the Nigerian situation, but I can't help it. But you know, we don't know the number of people who are unemployed in Nigeria at the moment. We can't tell. We can't tell because we don't have data, reliable data on it. So unemployment leads to depression, leads to anxiety. Economic stress, socioeconomic stress as we continue currently experience, leads to depression and anxiety. Insecurity leads to depression and anxiety. Cultural expectations, all of these things can further exacerbate depressive vulnerability. Now, another thing that we want to look at is anxiety. Recall we are looking at understanding depression and anxiety. So anxiety refers or arises when normal fear responses become excessive, persistent, or disproportionate to the situation, right? When we talk about anxiety, we talk about generalized anxiety disorder, panic disorder, social anxiety disorder, specific phobias, and so forth. They are not necessary for our interaction, but there are, just to say that there are so many types of anxiety. Clinically, anxiety involves heightened physiological arousal, rapid heartbeat, the person begins to palpitate, and then muscle tension, we have dizziness, and we have cognitive symptoms such as persistent worry, catastrophic thinking, difficulty concentrating, and all of those things. There are some of the attendant the things that people manifest when they experience anxiety. Just to talk about the neurobiological linkage, anxiety is linked to hyperactivation of the amygdala, again to the brain, dysregulated HP axis, what we refer to as hypothalamic pituitary adrenal axis, and so forth. Then again, serotonin is also indicted. You know, I mentioned serotonin before, that it's part of what's indicted when you look at depression. Serotonin, that neurotransmitter, is also indicted with regard to anxiety. That's why in treating anxiety and depression, we use medications within the class of what we call SSRIs, selective serotonin reuptake inhibitors, that inhibit the reuptake of serotonin. We'll talk about that in a bit. So anxiety is prevalent among adolescents, university students, young adults, individuals facing chronic uncertainty. Patterns like this have been documented immediately after the COVID-19 pandemic. In terms of prevalence and global burden of depression and anxiety, recent studies show that depression and anxiety affect over 300 million people globally, with increased incidence since 2020 due to prolonged stress, pandemic disruptions, and of course, economic hardship. This is according to the World Health Organization. In fact, a study conducted 2 years ago by Gonzalez, Martin et al. Showed that university students and early career professionals show heightened vulnerability with up to 42% reporting clinically significant anxiety symptoms. So young people, now we have an anxious group of young people, depressed group of young people world over. In Nigeria, community mental health surveys show that there is an increase in emotional disorders. The other challenge we face in our own context in Nigeria is the challenge of data. Again, back to data. We do not have very reliable data in terms of the number of people who are depressed, the number of people who have anxiety, and so forth. But people, the underreporting situation that we have with regard to this is tied to cultural stigma, limited mental health support. So the global burden of these disorders underscore the need for early detection, evidence-based intervention to prevent severe outcomes such as functional impairment, chronic disability, and of course, suicide, which people tend to have when these disorders persist for a long time. Then that takes us to some of the contributing factors when it comes to anxiety and depression. Let's look at biological factors first. First is the genetic vulnerability. Data shows, as recent as 2025, shows between 30 to 40% heritability estimates for depression, and then up to 50% for anxiety disorders. What does it mean in layman's terms? It means that if a parent has depression or anxiety, that there is a higher percentage or higher possibility that the children would have it. People talk about concordance rates. So genetic vulnerability is there, 30% to 40% for depression and 50% for anxiety. Now, whether it is as a result of genetic transmission or as a result of environmental vulnerability, so to speak, how the children are raised, that's a conversation for another day. Now, we also have what we call neurobiological dysregulation that contributes to anxiety and depression. Neurobiological dysregulation, what I mentioned earlier, dysregulation in the HPA axis and so forth. Cortisol imbalance, impaired neuroplasticity, increased vulnerability. Some of these things, cortisol is the stress hormone. So once there is an imbalance there, it could lead to depression and anxiety. And then brain structure changes. Studies have shown that heightened activation of the amygdala tends to increase anxiety, especially. And then we also have medical conditions like thyroid disorders, chronic pain, cardiovascular disease, hormonal changes, and so forth. They trigger depression and anxiety. And then it's important that we understand these biological factors so that when we are encouraging people to go for treatment, we encourage them to explore an integrated approach instead of individual isolated systems, so to speak. What are the psychological factors underlying depression and anxiety before we explore the social and environmental contributions? Psychological factors. Now, psychological theories attribute depression and anxiety to maladaptive cognitive patterns, how we think, our thought process. They also attribute it to negative self-schema, also attributed to insecure attachment styles and ineffective coping mechanisms. Let me just talk about what Aaron Beck said. So Beck's theory of depression explains that people develop functional beliefs such as helplessness, worthlessness, or catastrophizing that distort their thought process and increase emotional distress. And I will explain it briefly. So according to him, he said something about depressogenic schemata. The individual's thought process has become centered on depressive ideas and thoughts. Good. So let's say a young lady, Miss Table. Yes. So I don't call someone's name and we begin to Miss Table or Miss Cheer. So Miss Cheer or Mr. Cheer has depression. According to Aaron Beck, he says, according to his theory, the person has a negative view of the world, negative view of the future, and then negative view of themselves. So this triangle he called cognitive triad would lead to an infinite loop of depression. The thoughts would always be negative. So Miss Cheer goes out, interacts with people, and so forth. And you ask Miss Cheer or Mr. Cheer or Mr. Table how his day went. And what would the person say? Oh, it was very bad. Why? Because the individual is tied to an infinite loop of depressive thoughts, depressive ideas, and so forth. According to the to psychologists, of course, we have the theory of learned helplessness. That is persistent exposure to uncontrollable stress. It tends to lead to resignation and depressive symptoms. And then this learned helplessness is what we experience a lot in Nigeria. People, you try and try and try, and then you're not able to make very good progress. You learn to be what? Helpless. Learned helplessness. And then avoidance behavior. Anxiety, for instance, is reinforced through avoidance behaviors and heightened sensitivity to perceived threat. And then we also have what we call maladaptive patterns, according to psychologists, that could exacerbate depression and anxiety. Maladaptive patterns, something like excessive rumination. For instance, excessive rumination, perfectionism, poor emotional regulation, they are linked to depression and anxiety, especially among young adults. Let's take rumination, for instance, excessive rumination. What is rumination? The individual starts thinking about feeling bad and stays in that loop, never-ending loop of why am I feeling bad? And this world is, I'm not liked. People do not like me. People hate me. Nothing is working for me. All of that negative thought about what's happening to them now becomes a cycle that they are not able to break out of. So excessive rumination, then perfectionism, they want things to be in a certain way. And then when they are not able to regulate their emotions, then it could lead to depression and anxiety. What are the social and environmental contributors? Recall that we've touched on the biological factors that contribute to depression and anxiety. We've talked on the psychological factors that contribute to depression and anxiety. What of the social and environmental contributors? Then this one hits home because that's what we experience in our context in Nigeria. Environmental stressors. You talk about poverty, you talk about unemployment, you talk about academic pressure, you talk about national conflict, you talk about workplace discrimination, you talk about trauma, you talk about chronic illness. All of these heighten the risk of depression and anxiety. In fact, recent evidence from low and medium income countries like ours shows that social instability, insecurity, economic hardship significantly predict emotional disorders. And then amongst young people, things like social isolation, digital overload, unrealistic societal expectations, and the pressure to achieve success, especially on social media, exacerbate anxiety. And then in our own context, again, in Nigeria, for instance, cultural norms, right? Cultural norms tend to encourage emotional or reduce emotional expression. It leaves people without safe outlets for psychological distress. And then it increases risk when it comes to depression and anxiety, and then it delays help seeking. Now, what are the signs we should look out to depression with regard to anxiety? What are the early emotional and cognitive signs that we should look out for? So we'll talk about the emotional and cognitive signs of depression, and we'll have to also explore the physiological and behavioral signs while we explore the same with regard to anxiety before we touch on some treatment modalities. For depression, it begins with subtle emotional changes before we begin to see more severe symptoms. Persistent sadness, the individual becomes persistently sad. Irritability, emotional numbness, loss of interest in previously enjoyable activities, general sense of emptiness. So these are some of the questions we ask when we want to diagnose depression. Then we look at things like cognitive impairment, difficulty concentrating, memory lapses, indecisiveness, reduced problem-solving abilities, and so forth. So people may begin to interpret neutral events negatively. Sometimes they withdraw socially. So these are things you want to look out for. Is this individual withdrawing socially? Somebody who used to be extremely adventurous, who used to be very, very sociable, who used to be extroverted, now withdraws. You have to ask questions. Sometimes people feel overwhelmed. You want to ask questions. So studies show that early cognitive and emotional symptoms often appear weeks before clinical depression becomes fully diagnosable. When you detect some of these things early enough, it helps with regard to prevention and intervention. What of the physiological and behavioral signs when it comes to depression? Things you might want to look out for: changes in sleep, appetite, energy levels, physical functioning, fatigue. Person is always tired. Insomnia, oversleeping, reduced appetite, overeating, headaches, gastrointestinal issues. These are things you want to look out for. So recent research indicates that physiological disruptions, especially sleep changes, they are among the earliest and strongest predictors of depressive episodes. Again, recognizing these signs, these physical signs, would help clinicians and caregivers detect depression early enough. Then we turn our attention to anxiety disorders, early signs of anxiety. What do you want to look out for? They begin with persistent worry, persistent excessive fear, muscle tension, sleep disturbances. So people would sometimes experience restlessness, difficulty relaxing, racing thoughts, hypervigilance, anticipating worst-case scenarios when they're not supposed to do so. And then we have things like palpitations, sweating, trembling, dizziness, gastrointestinal discomfort, and so forth. Sometimes people will avoid social events, withdraw from responsibilities, or seek reassurance from others when they don't need to do those things. So recent studies show that early anxiety symptoms intensify during academic transitions, during financial uncertainty, during relationship strain. Again, early identification is extremely, extremely important. What are the ways that we screen with regard to these two disorders? Well, we use screening tools. In clinical psychology, we use things like the PHQ, Patient Health Questionnaire. We use the GAD-7, General Anxiety Disorder Scale, for anxiety assessment. And we also use clinical interview. So we use some of these instruments. Elevated scores on some of these instruments would show anxiety or depression, depending on which one you're assessing for. Then we now explore some of the treatment approaches with regard to depression and anxiety. Treatment approaches. Well, we have CBT, which is cognitive behavioral therapy. This is one of the most effective, in fact, it is the most effective first-line intervention for mood disorders, anxiety disorders across all cultural backgrounds. One of the fathers of CBT, Aaron Beck, talked about, that I mentioned earlier, talked about the presogenic schemata. And then we have acceptance commitment therapy, other therapies like interpersonal therapy, mindfulness-based cognitive therapy. They are quite strong. And studies have shown over time that when you combine psychotherapy with pharmacotherapy, that is drug treatment, that you have better outcome. We also have exposure techniques for anxiety disorders. Very, very important, just to desensitize the individual with regard to the fear responses. Then we also have biological and pharmacological treatments. There are so many medications that we now give these days. SSRIs, selective serotonin reuptake inhibitors. I mentioned it earlier. They inhibit the reuptake of serotonin. Though recent studies now argue that they see no reason why people still give pharmacological treatment option, since it is aimed at enlarging the pockets of pharmaceutical industry. But it's a discussion for another day. SSRI, Prozac and Pro. Then we have SNRI, selective norepinephrine reuptake inhibitors, that inhibit the reuptake of norepinephrine neurotransmitter, and so forth. And studies have shown also, we have two different schools of thought with regard to this. Studies have shown that this medication correct neurotransmitter imbalances, improve mood regulation, and reduce physical arousal, while some other people are arguing otherwise. And we have newer treatments that are coming up, like TMS, transcranial magnetic stimulation, and so forth. Again, medication is more effective when it's combined with psychotherapy and lifestyle modification. Talking about lifestyle modification, we look at some of the things that, in case someone is saying, oh, the person I know that has depression and anxiety, they don't have money. They don't have money for psychotherapy. They cannot afford it. They don't have money for medication, pharmacotherapy. They cannot afford it. Lifestyle modification is extremely important. So lifestyle interventions such as physical activity, sleep hygiene, balanced nutrition, digital wellness strategies, they improve depression and anxiety outcomes. Physical exercise, just exercise, running, jumping, doing anything, whatever you can do outside or inside would help. They reduce cortisol, enhances endorphin, improves emotional regulation. And balanced nutrition is also there. Diets high in fruits, vegetables, omega-3 fatty acids, they support mental health, while excessive caffeine, alcohol, processed food, they tend to worsen symptoms, according to studies. And sleep hygiene, because one of the things that people experience is dysregulated sleep. So sleep hygiene is extremely important. You have to improve your sleep pattern, reduce your screen time, practice relaxation techniques. All of these things contribute to recovery. Social engagement, engaging in social activities. Some of my clients who have depression or even anxiety, I encourage them to go out. So first thing is physical exercise, and do anything, take a walk, and so forth. Social engagement, just go out. Don't be a couch potato. Just go out. So engaging in social activities complements psychological and biological treatment, creating stronger and more sustained outcomes. And then we talk about social support. Social support is extremely, extremely important. It plays a critical role in preventing, managing, and recovering from depression and anxiety, because a strong social support network provides emotional buffering, reduces isolation, and then it helps when it comes to enhancing treatment adherence. People would ask you, how far with your treatment? Are you still going? And all of those things. And then studies have shown that individuals with robust social connection experience faster recovery, lower relapse rates, and improved resilience. So social support can come from different areas, from family, friends, mentors, peer groups, religious communities, mental health professionals, wherever, from different places. And then that takes us to cultural beliefs in depression and anxiety. Now, culture tends to shape how people understand, express, and seek help when it comes to depression and anxiety. For instance, in many African communities like ours, or societies like ours, emotional distress is attributed to spiritual causes, moral weakness, or external adversaries, which can delay professional help seeking and reinforce stigma. For instance, in Nigeria, social expectation of emotional toughness, especially among men, inhibits disclosure when it comes to anxiety, when it comes to depression. And when it comes to young people, again, that takes me to young people. I already mentioned that young people are the worst hit with regard to depression, with regard to anxiety. When it comes to depression and anxiety, university students and young adults, they are part of the highest risk groups for depression and anxiety. You look at things like academic pressure, uncertainty about career prospects, financial constraints, social comparison on digital platforms. All of these things heighten vulnerability. They are watching TikTok and they are seeing people who are telling them that they have started 84 businesses in 84 days and they want to be like them. It's not possible. Most times, young people lie online. So they see such things and then it causes depression, it causes anxiety. They want to be like the Joneses, forgetting that those things are extremely fickle. I recall one of the clients I treated, I think that was last month or last 2 months. Yeah. He was very suicidal, had high level of depression. In fact, I used an instrument called the SCL-90, symptom checklist 90, to assess his depression. He had 40 something out of 10, I think 10.15, which is the norm for men. So it was off the roof, so to speak. And this person had over either 3 or 4 million followers online, and he was telling me, I am all alone in this world. I found it extremely amusing. I said, what of your 4 million people following you online? I mean, why would you be alone when you have 4 million people behind you? I said, I should not mind those people that they're not, So it does that reiterates the fact that we shouldn't depend on all of those things to decide how we live our lives. And we should also enlighten young people in this regard, right? People post all sorts online. And sometimes young people would see those things and then it would cause elevated depression and anxiety without knowing that most people are just posting fake videos and all. And then, of course, in the workplace mental health is a growing area of concern as emotional disorders increasingly affect productivity, affects absenteeism and job satisfaction. But the worst part of it is what we call presenteeism. The person will be there in body, but not in spirit, or not add any value to the organization. So international studies show that employees experiencing depression or anxiety, they have difficulty concentrating, reduced motivation, decreased creativity, increased conflict with colleagues, and so forth. And then when it comes to the interplay between depression and anxiety, before we touch on support strategies that we can offer and begin to wrap up. Interplay between depression and anxiety. It's interesting to note that they overlap. Research shows that 50 to 60% of people diagnosed with depression also meet the criteria for an anxiety disorder. So earlier, I talked about comorbidity. Comorbidity is, in terms of these disorders, comorbidity is one of the most common presentations in clinical practice. So when you assess for depression, you have to also assess for anxiety because most people who have depression also have anxiety. And sometimes studies have also shown that depression precedes or anxiety precedes depression when you become extremely worried, insomniac, lack of sleep.
5 minutes to go.
Say that once again.
5 minutes to go. Sorry to disturb you in your thoughts.
Yes, I have my timer.
Okay, good.
Yes, thank you, sir. So anxiety precedes depression, like I said, and depression now again intensifies anxiety. It's like, again, a never-ending loop. Depression, anxiety, depression, both of them just playing together. And then we talk about the role of adverse life experiences, trauma. Studies have shown that exposure to trauma, like violence, abuse, accidents, conflicts, sudden loss, all of these things increase the risk of developing depression and developing anxiety. And studies have shown that trauma sensitizes the amygdala and disrupts the HPA axis and impairs emotional regulation pathways, and then it creates a long-term vulnerability with regard to depression and anxiety. And in our context in Nigeria, exposure to communal violence, displacement, socioeconomic instability, they place many people at risk when it comes to depression and anxiety. I've already talked about social media and digital stress. It's important that I touch on it and reiterate that again, that digital platforms have transformed communication, but they have also intensified psychological stress, like excessive screen time, algorithm-driven comparison, like I mentioned, cyberbullying, unrealistic lifestyle portrayals, and all of those things, they increase anxiety, increase depression, create low self-esteem. Some of the things we might want to do in terms of early intervention and prevention strategies, psychoeducation and screening, right? Studies have shown that early intervention tend to improve treatment outcomes and reduces future reoccurrence of these disorders. So psychoeducation and screening, routine mental health screening, educational programs in universities, secondary schools, wherever, amongst adults, community settings, and so forth tend to help. Lifestyle education, like I mentioned, in terms of sleep hygiene, digital wellness programs, and so forth, they also tend to help. Community integration tend to help a lot. Resilience training also tend to help. And then we shouldn't forget the role of family support and community support. Studies have found that these two things, family psychoeducation significantly reduces relapse rates in depression and improves outcome in terms of anxiety. So community support, family support, and so forth, they tend to help a great deal. One of the studies I read a while ago about adults and depression, older people and depression, according to the authors, they said that adults or older people who live in community settings, they tend to have lower level of depression and anxiety because of the conviviality, collegiality that they experience within that community setting. And then for schools and universities, support strategies, things like counseling centers, peer support, wellness programs have been found to help greatly. In workplaces, things like organizational support strategies, EAP, I serve as a wellness advisor for some organizations, and that has been found to help staff stay healthy over time. And for those people who have depression or anxiety, it's easier to give them or help these days from EAP. And in terms of building long-term resilience and relapse prevention, well, preventive practices is one of the core things we encourage people to do in terms of anxiety, depression prevention. For instance, gratitude practices, practicing gratitude, behavioral activation, maintaining therapy check-ins, and all of those things tend to help a great deal. Gratitude practices, before you go to bed, list 3 things you are happy for today, and then that would help you be thankful. I'm alive today, I breathe well, and I can at least make the gratitude list. That's something to just check. And then you have to also identify triggers. People benefit from identifying relapse triggers like isolation, sleep disruption, chronic stress, and developing coping strategies, how to cope. So to wrap up our interaction this evening, it's also important to note that we can't exhaust everything with regard to depression and anxiety in 40 minutes or quadruple the time. But it's important to note that depression and anxiety, they are very complex, multifactorial conditions that require integrated approaches that address biological, psychological, social determinants. Early signs, whether it is emotional, behavioral, physical, must be recognized in order to prevent severe outcomes. So contemporary psychological research, like we have seen between 2020-2025 affirms that effective treatment combines psychotherapy, medication, lifestyle modification, community support, and stigma reduction. So we have to try as much as possible to put our hands together and do our bit in order to help people who have depression and anxiety, and help people not to also have it. Thank you.
Thank you very much. That was extremely wonderful. My only regret, Dr. David.
I'm with you.
Dr. David, can you hear me?
Yes, sir. I'm with you.
My only regret being in Nigeria, if this was a webinar on the 7 secrets to spiritual success or how to make $1 million, we would have had hundreds of followers. But a very important thing like this, particularly when you talk about, I'm a trained social worker and I do believe in the social economy determinants. An important thing like this topic, even members of the Nigerian Mental Health Organization, we have not signed up to it. So it's sad in that sense, but obviously we have to keep on digging on. You mentioned older people like me that are retired. That's one of the reasons why I'm back in the UK, because I found myself getting depressed. You know, I don't want to end up as a social alcoholic in Nigeria. So let me come back for a couple of months and go back. But no, seriously, and you've done a justice to it. It cannot be done in 45 minutes, but even for me, there are learning points. I don't know whether you have anybody has any questions, but I would like to share what I'm trying to do. I'm working with an organization called Ilera Community Health, based in Abuja, and we're trying to do a pilot where we're training primary healthcare practitioners in free catchment areas. So on the outskirts of Abuja, in Badagry, and in Katsina on understanding depression. We just practice depression, not even anxiety, and using using solution-focused work as a means. And we've done Katsina, and they're flying. They're talking about how they want to continue. So it's clear it's an important topic. So despite the low numbers, please keep the education talking going. We need to, and you need to probably go on TikTok or YouTube, because there are too many unprofessionals that are giving fake information. We need more professionals like yourself going on TikTok and YouTube and talking about these things. So I don't know whether anybody has any questions. Yes, I'm seeing them are having some questions. Okay. Yes.
I do.
Yeah, thank you, sir. I sincerely appreciate him. He did justice to it. So, and I'm sorry that I came in late. I'm in Maya. I traveled for examination supervision. So, yeah, please. My question is, how did you get the percentage? How were you able to diagnose and get the percentage? When you talked about the guy that was depressed and he had so many followers, over 1,000 followers in his social media. So how do you get that percentage? The measure you use, the instrument you use in getting the percentage.
Thank you, sir. So I said I used the SCL90, symptom checklist 90, and he had about 4 million followers. He's extremely popular. For 4 million followers. So I used the SCL90, and when you look at this, questions like loss of sexual interest or pleasure, feeling low or slowed down, thought of ending your life, crying easily, feeling of being strapped or blaming yourself for things, feeling lonely, feeling blue, worrying too much about no interest in things, feeling hopeless about the future, feeling everything is an F, and then feeling of worthlessness. So we use a 5-point scoring for this, right? So on what you take, we'll now use it to calculate your outcome. That was how we got to the, yes, it's
Okay.
Thank you very much. Thank you very much.
Okay. So mine is more of a comment than a question, even though I will have question or two. And it's important to understand, my role here. I am the secretary of the board of directors of the Nigerian American Institute for Mental Health, the organization that is, arranging this. So, because as Yomi said, this topic is a very important one, I insisted that only someone who practices, who has treated someone for anxiety and depression will present it. And it took some time to find Dr. Igbokwe. And to be honest with you, I'm very, very impressed, by the presentation. I couldn't have asked for anything different. And the best part of it, and what I was looking for, because I practice in the US, and my background is not psychology, it's social work. I'm a clinical social worker. So I was looking to see, how you guys practice in Nigeria, particularly when it comes to treating depression and anxiety. And the good news for me, maybe Achike might have something to say, is that I didn't see any, major difference, whether it is, how we perceive or screen for anxiety and depression, or how we treat it, or what we tell our clients. I didn't see any difference. Maybe the cultural belief, even the cultural beliefs, some of it is still shared across the Atlantic. I think the only thing I didn't hear that we normally tell our clients who are depressed is to emphasize that it may be difficult, but depression is treatable. We try to emphasize that it's treatable. That's the only thing I didn't hear you say. Yeah, otherwise, I think you did, a very important job. And the other thing I wanted to, two things really, but it's more about getting more information. One is you made reference to community mental health surveys in Nigeria. I would like to know more about that. Who does it? What's this showing? Even if you can't answer that now, it's something maybe we can follow up on. That's one. The other thing is you were making reference to EAP, and if EAP means, as we understand it, employer assisted assistance programs. I'm also, it's interesting to know that it's, happening in Nigeria because it's a major tool or help for workers, who are going through mental health issues. Particularly, I think it will be even more important in Nigeria here, where you don't have a health insurance program that people pay with. So those are really my observations. I don't really think there's anything else that that I think was not done right or that I worried about. Some of the questions I thought I would have been answered. So thank you so much for the presentation. Yeah.
Thank you very much, sir. Okay, so talking about the mental health studies in Nigeria, authors like Bola Ola, professor of psychiatry, I've worked with him. He's done quite a lot in that regard. Adewiya, Professor Adewiya, also, he's done things in terms of anxiety. In fact, they validated an instrument to assess depression and anxiety locally. I'm trying to remember that particular. And so there are a handful of works being done here and there, but not at the level that we anticipate. So a few things here and there, not so strong, but they've been coming with data is sparse again with regards to it. And now, because I also examine MSc PhD students, they conduct surveys with regards to this. So that's the much I can say to that. A few authors here and there have been conducting research in this area. Those are the names that easily come to mind. Then, in terms of EAP, I think it was in 2012 that EAP started in Nigeria formally. The first meeting was held, sorry, they're calling me for another meeting. So the first meeting was held at the, I can't remember the hotel, but it's in BI. So that same 2012, I was elected the Secretary General of the EAPA Nigeria, Employee Assistance Professional Association of Nigeria. And then we started work. So we were able to register EAP in Nigeria in 2012. And sorry, not 2012. From then we started work. I think it was in 2015, 2016-ish that we were able to register EAPA Nigeria. And then during the course of my work with the EAPA Association in Nigeria, it was, I think, something Blair, Brenda Blair, that came to Nigeria that year, and then the national president of EASN from the US came also that year to help us establish it. And it's sad to say that that was September 2013, the association elected the first members, so to speak, executive members, which I was elected secretary. And 2016, we had an amazing conference, EAPA conference, Nigeria. By 2021, I handed over to another group of people. They are still, it's still in its infancy. It's sad that after so many years, you know, the Nigerian factor, I'm sorry to say, but we are all Nigerians. Hiccups here and there, you know, teething problems still since 2013. So I still attend events, and I remember I went to South Africa to make a presentation, I think in 2016, it was 2016-ish, yes. I made a presentation. Now, South Africa was somewhere if we had used the same level of tempo that we started with, we would have gone so far in Nigeria. In 2018 or 2017-ish, someone, Venerable Adelowo Adesina, he's one of the people pioneering EAP in Nigeria at the moment. Venerable Adesina, he is the CEO of Sages and Scribes Consultants. He's been pushing the organization. He's been doing a whole lot, investing his own personal funds just to make sure that we move forward. You know, like South Africa, he goes to South Africa almost every year. He goes to the US, the big EAPA International in the US. He goes to for their conference. And he's been desirous of Nigeria having the same level of impact that is being experienced in South Africa and in the US. But I wouldn't know what's happening. We've not gotten that gotten to that level. We've not been able to push through that glass, whatever ceiling it is, whether it's glass or marble or iron or concrete ceiling. We've not been able to push through it for some years. Then some organizations have EAP, right? There was a time CEPLAT called me to help establish a former EAP. I sent in a proposal. It couldn't just take off. But they have an internal EAP modality that they run. Organizations like Chevron. So again, just as you said, sir, it's a very strong thing when it comes to other clients, right? Chevron has a very strong EAP unit. The person that served as their EAP advisor and left after many years, we worked together. He was the president of EAP in Nigeria at some point and then moved on. And a few other organizations, right, have very strong EAPs, but it's difficult to just get that integrated in the national system, just the same way we are unable to integrate mental health into the national health scheme and all of those things in Nigeria. That's the same issue that we are having. We know that this thing is going to help organizations thrive. It's going to help people within organizations thrive, but government is not helping. Individuals also have their own challenges. Now, in other sectors, for instance, IBM, for instance, HP Nigeria, then, for instance, Syngenta Nigeria, for something like an organization like British Council, and so forth. Now, they use EAPs from outside the country. So all their EAPs are from outside the country. So they have affiliates in Nigeria that service them. And that's also part of the reason why we are not able to make very good progress, because some of the top organizations that should be having internal EAPs do not have. So they contract it outside the which outside now teach people from Nigeria to do this. So it's quite interesting. That's the most I can say. We've not really taken that flight after so many years. It's sad, but that's the situation we've found ourselves in, and we are just hoping that hopefully we'll get to that point where we have functional EAPs in all of the organizations in Nigeria. We're mooting having EAPs even in government organizations, government-owned, not government-run organizations, but we've not been able to also do that. I was part of a training that Venerable Additional organized in Bonny Island for LNG. So we've been saying, okay, LNG should also have an internal EAP. We are still, so all of those things are some of the challenges we've had over the years. It's not as if these organizations don't know the importance of all of these things. They do know, but bureaucracy and so forth do not allow things move forward. We can only do what we know best to do, and it's sad that as a professional, I'm saying that we have to keep hoping and keep praying for something to change, you know. But if it is pushing things to change, we've been in the forefront of this particular struggle, trying to ensure that things takes a different turn. Hopefully, at some point, we'll get to that point. Thank you.
Can you hear me? Yeah. So one of the things the letter wants to do this year is a small private research on primary healthcare and depression, because the primary healthcare boards aren't working for us. We spend millions of naira doing programs, and then when we say the grants finish, can you continue? They will say they have no money. So we said, okay, we're going to work in our free catchment areas. We're going to work with a number of primary healthcare in those catchment areas, and we're very clear with them, those in the catchment area, and a number of schools in the catchment area, with the aim of helping develop the skills in assessing depression, working. Great that you mentioned young people. I was reading an article. They said African young people are the most depressed among young people around the globe. And this whole thing about loneliness in millions, loneliness in midst of many. So we are going to work with a number of secondary schools and a number of primary healthcare centers in our catchment areas. and we hope to come up with some private research and put it on, public domain. But it's sad that these things don't cost a lot of money, but our governments unfortunately don't. It was like all the noise when the Nigerian mental health bill was passed. And I said it's one thing for the bill to be passed. It's another thing for the money to go with it. Because it's just, and I think that's part of the problem, that there isn't a lot of investment. Could I just ask, EPA, I remember Dr. Zubike, he mentioned it. What is it called? EAP, what does it stand for?
Okay, here it's called employee assistance programs, in which employers would send some of their own the employees to us for treatment, and after the treatment they pay us directly. They don't have to go through the insurance. Sometimes even those who have insurance, they do the EAP sessions first before transitioning to their own private insurance.
The reason why I was asking that is that I've so far been invited by 3 relatively middle-level organizations in Nigeria to do emotional and mental well-being in the workplace. So that's probably more preventative. So I didn't know, because the issue has always been how to refer on. They've always asked me, and so I will be raising that with them. EAP, they need to work with organizations that do EAP. And I think we also need to know, those of us in the primary healthcare sector, how do we refer on to hospitals? So Dr. David, if we have people who have recurring depression in Abuja, where do we refer on? These are big issues for us.
So
because as you know, people that use the primary healthcare system, they don't have money for people like you.
So I know that there is a psychology unit at the National Hospital and Carol General Hospital. Yes, I know clinical psychologists in those clinics. And then the University of Abuja Teaching Hospital, there is a psychology unit there. They have very strong, they are my colleagues, and they would help anyone who is referred to places. Yes, we have clinical psychologists who are licensed in those hospitals: Carol General Hospital, University of Abuja Teaching Hospital, and National Hospital Abuja. For the FMC, I cannot. FMC, they have a mental health unit, but it's outsourced to an organization outside of the hospital. So that's why I'm not mentioning it. But for these 3 hospitals, have resident clinicians there that work with them, with clients.
I think Ozioma's hand has been up for a long time.
I was going to ask. Yes,
sorry. It's a mistake. Okay. I didn't know I had to stay on. Sorry.
No, please go on. Yep.
No, not supposed to again. My God. I have unlimited attend. I said, even the energy to hold it up for so long. So I just wanted to, concord the appreciation that our president expressed, Dr. Azubike. It's really very refreshing having this engagement with you, David. So,
Thank you,
one of the things that I included when I was responding was, if are we charting any new grounds in terms of psychosocial and herbal integrative support for clients that are coming, or individuals that are struggling with this issue, especially because listening to the instruments that you guys use in assessing for depression and
anxiety is just like a transplant from what we are used to using here in America. So I do remember that I think it was in 2004, I believe, there was a cohort of people that in the diaspora we are trying to promote the herbal remedies that we are growing. Unfortunately, now it's not unfortunate, but South Africa has been on the map, for that. But then Nigeria is missing in the conversation of exploring those resources. So I'm just curious to know if you have any thoughts on that. Thank you.
All right, thank you very much, sir. Incidentally, I am not aware of anything currently happening, except maybe within the psychiatric space, because some of the psychiatrists are the ones exploring these things. Psychologists continue to use most of the instruments developed in the West, because to conduct studies within Nigeria is difficult, and sometimes part of the constraints, of course, the institute has also added now to the mix. Funding also is there, so forth. So most of the studies in terms of instruments developed locally, they are either conducted with university students or people within the university community, and some of them are not out there. You can't find them out there because of, again, we go to digitalization. Some of those things are not put in repositories where you can see them. There are instruments that are indigenous. For instance, something like the Enugu somatization scale, developed by Professor Peter Ebibo in 1982, is there. And a few instruments here and there. And then the other part is that, again, I will have to mention that some of the Western instruments, they have been validated here. And some of us believe that once they are validated, it means that we can use them without taking into consideration the nuances with regard to our manifestation of some of these things. Again, that's why I also, in my practice, I use Enugu somatization skill a lot. We all know that somatization has to do with using the scapegoat, so to speak, using the body to manifest psychological issues. So apart from such instruments, I am not aware of other ones, except maybe within the psychiatry space. I'm not very much aware. Yes. Thank you.
Okay. Yeah, I mean, you wanted to contribute to that?
Sorry, sir. That any aspect of the question? I don't know if I did.
I have just one question. You made reference to licensed psychologists in Nigeria, and I'm wondering who licenses them. Is it a professional group? Is the government organization? How are psychologists licensed, and at what level of education?
All right, sir. So we have the Nigerian Association of Clinical Psychologists, the umbrella body of clinical psychologists in Nigeria. And this association came into being, it was established in September 1979. Yes, precisely 79. And It's been there since then, although we have had some gaps in terms of activities. But I can confirm that since 2010, no, 2008, I attended a conference in Edo State. Since 2008, we've been having consistent engagement in Nigeria. In 2022, we had a conference in Abuja, Nigeria Association of Clinical Psychologists. I chaired, I was the chair of the local organizing committee for that particular conference in 2022. It held at Bayes University. And then in 2025, November, I also served as the LOC chairperson for the conference that's also held in Abuja. We looked at mental health in emergencies, the role of clinical psychologists as the theme of that particular conference. And I think we held part of it at Sandralia Hotel and then 3J's Hotel for the continuing education training. So the organization that's licensed psychologists in Nigeria is the Nigerian Association of Clinical Psychologists. Interestingly, I serve as the chairperson for the Abuja chapter of that association. And Professor Gloria Karuri is the current president of the Nigerian Association of Psychologists. So it's the body that regulates, so to speak, clinical psychologists in Nigeria currently. And it's a part of the Nigerian Psychological Association, an umbrella of psychologists in Nigeria, or the umbrella organization of psychologists. Yes. Thank you.
Thank you for that. I was going to say in comment to, in relation to more talk therapy, I did a year's piece of work in Uganda, and it's amazing what we could learn from some of these East African countries, our brothers and sisters there. They've got a program called Friendship Bench that was started in Uganda and has been replicated across the modern Western world. It's an African tool. And I'm surprised it hasn't taken up in Nigeria, because obviously it does need a commitment. And you mentioned, Dr. David, you mentioned CBT. One Ugandan university, I can't remember which one, their students won a prize because their students developed a model where you don't need to know how to read and write, because normally CBT you have to make notes, and it was done in a local Lingala language. So I think some of these problems we have in Nigeria is a matter of commitment from our government, because it does take some money. You know, individuals, it's all well and good us individuals doing little projects, but our government needs to know that, yeah, they need to be committed. There are models out there. You mentioned South Africa. I remember some years back, South Africa wanted to do a program with me, unfortunately didn't. So I think we should learn, even though we call ourselves the giant of Africa, I think we do need to learn from our Southern and East African brothers and sisters doing mental health work in the community there. So I don't know, is that all? Is that seem to be any other question from anybody? If they put your hands up. If not, I offer a very big thank you to Dr. David for you spending this valuable time to give us this valuable message. I've learned a lot and I'm still learning. And as I said, we need to continue passing this message on. Thank you to the Nigerian American Institute of Mental Health as well. And thank you to those of you that came on to listen. And I hope next time the message goes out and more people listen to it, not because we want many followers, but because what is being said is very important to our mental health in Nigeria. We Nigerians, many of us have mental health issues and we don't know it. So we need to know these things like what you've just said. So thank you very much. On that note, I think I could call it to the webinar to an end. Well done, everybody. Have a nice Saturday weekend, and we await the next one. Thank you very much.
Bye-bye.
Bye, everyone.
Bye.
Levante UD Atletico Madrid. Match finished 0-0.